what am I going to do? Today I'm going to talk predominantly around some case-based discussions, because otherwise it can all get a bit boring. The remit I was given is actually quite huge, so we've got just under half an hour to have a whistle-stop tour of some of haematology. So I'm not convinced we'll get through it all, but this is what I'm going to talk about today. Stop and ask me questions as I go along, or there's a bit of time for questions at the end, but I'm very happy to be stopped as we go. So these are all true cases. The first one is a 24-year-old woman. She presented 38 weeks gestation, admitted in labour. This was her full blood count at the time she was admitted. So, is anyone going to volunteer any thoughts? Might as well let you do some work. So she's got a normal haemoglobin. For late in the third trimester, that's quite healthy, obviously. She's not become iron deficient. We're quite happy with that. She's got a high white cell count. Should we be worried? No. White cell count goes up in pregnancy, so we're happy. But she's obviously thrombocytopenic, isn't she? So, when we, as haematologists, see a new thrombocytopenia, what do we always ask you to do? Repeat it. Repeat it. Because quite often it's a sampling error. When the sample gets taken, you can often see that you can get small clots in the sample. And so if you do a blood film, we can see lots of clots. And often in the new analyzers, the biomedical scientists in the lab can see if they look like there are platelet clumps present. So we often do say repeat it, and sometimes we say repeat it in a heparin tube or a citrate tube as well as the EDTA tube to just confirm that it's a true thrombocytopenia. So the haematologist was asked to see this lady. She was otherwise very well, no concerns whatsoever. Blood pressure was fine. She had no history of bleeding in the past. Why did we ask that? In case it was a pre-existing thrombocytopenia or a pre-existing bleeding disorder. No other medical history, had no medication. Examination, nothing of concern other than she was in labour, obviously not of concern to you. CTG was fine. Now, booking bloods were normal, platelet count 158. The 28-week blood platelet count was 108. So what are we thinking about? Pregnancy-induced thrombocytopenia. So one of the most useful things you can do is see what your previous counts were. And obviously, ICE is very useful. Remember to unlock a filing cabinet in STH. If you look in the ICE in Sheffield Teaching Hospitals, at the right top corner, you'll often see a little brown box that looks like a filing cabinet. They automatically file any results more than 6 to 9 months old. But if you press that little box and then log out of the patient and back in, they'll give you all the history you've got back the last 5 years. So it's often quite useful to do that if you didn't know. And obviously we've got ICE intranet, so OpenNet for the region, so we can look at counts in the region. It's transformed our working lives. It's made things much easier. But her platelet count was normal. It's 158 at booking. So our lower limit of our normal range is 140. So it was essentially normal. But clearly there's been a drop. By 28 weeks, it was dipping down, and then it's down to 58 now. So the most likely cause is gestational thrombocytopenia. So we like to have a very long differential diagnosis. We're increasingly understanding that there's far more inherited thrombocytopenias round and about than we ever thought there were. Now, we're more often testing people's full blood counts. We're more often finding individuals with platelet counts running somewhere between 70 and 130 for no obvious cause. So, and we're now finding various genes that are associated with that, so inherited thrombocytopenias. And if we've got somebody in that circumstance, it's important that we ask about bleeding, because some of these inherited thrombocytopenias are associated with bleeding disorders. There's one, the Bernard-Soulier syndrome, is a platelet disorder where you've got big platelets and you bleed. And von Willebrand's disease, some types of von Willebrand's disease, you can get low platelets. So we always think, could it be inherited? Have they bled in the past? Various acquired ones, viral infection, bone marrow disease, etc. And then in pregnancy, we consider gestational thrombocytopenia and then microangiopathy, so DIC, HELP syndrome, pregnancy-induced thrombocytopenia, PET. This woman is otherwise very well. There was nothing to suggest microangiopathy, nothing to suggest anything else. It looked like she had gestational thrombocytopenia, which is very common in 10% of pregnancies. The platelet count will fall to often to less than 100. And I have seen a couple of individuals who've had very significant pregnancy induced thrombocytopenia, the platelet count falling down to the teens that has recovered after delivery. It's described. There's a dozen cases in the literature. So more often, so she had a gestational thrombocytopenia. Yes, and now, so common thrombocytopenia, most circumstances, the platelet count's still within the normal range. Of those that are low, gestational, preeclampsia help, autoimmune, or unusual causes. What do? We repeat the full blood count always. This lady's in labour. This is what we would like to do, but this is not necessarily what we did in this case. So repeat the full blood count in film, which we did do. Coagulation screen, because obviously if the coagulation screen is abnormal, suggestive of DIC and other more significant disorders. One, I'm sure that you all know this, apologies if I'm going over old stuff, but if you get an abnormal APTT in pregnancy, then that is abnormal. So in pregnancy, the APTT will shorten. So your normal range is, say, 22 up to 35. Because the fibrinogen goes up in pregnancy, factor 8 goes up in pregnancy, it's an acute phase response, your APTT should shorten. So if somebody develops a prolonged APTT, then that is something to be concerned about. Always ask haematology. Viral serology, hematinics, antiphospholipid antibodies, and these if we're really stuck. So this woman, the repeat platelet count showed platelets of 64. Film showed large platelets, again, entirely in keeping with ITP. You get big, meaty platelets that are very effective at doing what they need to do. Her coagulation screen was normal. Fibrinogen was high, again, as one would expect in a normal pregnancy. So we felt that she had gestational thrombocytopenia. We couldn't necessarily exclude ITP. How would we exclude ITP? Yeah, so basically in 3 months' time. So basically in 3 months' time we'll make sure we repeat the full blood count and see if it's normalised. And if it's normalised, then it was gestational. If it hasn't normalised, it's ITP. So ITP is a diagnosis without a test. So it's a diagnosis of exclusion. So we're often stood there scratching our heads thinking, is it really, isn't it? Which is very frustrating. But the way to prove it's not ITP is to check your platelet count once it's delivered. How would you manage your delivery? So, platelet count 64. I mean, this is your bread and butter, so I'm sure I feel as if I'm teaching my grandmother to suck eggs, really. But if the platelet count's above 50, we're very happy for someone to proceed to vaginal delivery without any support whatsoever. We're happy for her to go to caesarean section, but we would not. We would tend not to use regional anaesthesia unless we felt we had no option. We would not, if this woman had been 2 months earlier and the platelet count was 64, and I say I'd considered ITP as a diagnosis, would I have given her any treatment? Steroids? I don't know if I would, to be honest. I would have just watched the trend, because often giving steroids causes more problems than it solves. If it's important that someone has regional anaesthesia, it's very important to do so, then as she comes towards term, then you would consider giving treatment to increase the platelet count, which would be steroids or intravenous immunoglobulin. But we often just sit in these individuals and let them just carry on to term, because I said the differential diagnosis is gestational thrombocytopenia or ITP. If we're not sure, I try to avoid treatment where feasible. Is that contentious? We've got this lovely guideline, regional anaesthesia and patients with abnormalities of coagulation. All familiar, it's the Anaesthetic Society. It was published in 2013. Mike Macris is one of my colleagues in Sheffield, and he's one of the authors. And I apologise if it's not easy to read in the back, but effectively, this is regional neuroaxial blocks in obstetric patients with abnormalities of coagulation. In idiopathic thrombocytopenia, so again, I consider somebody with thrombocytopenia coming up to delivery, whether it's ITP or gestational, I consider them similarly with regards to the number of platelets. Do you? Would you treat them differently or the same? Same, yeah. That's what I thought. So platelets more than 75, then you're happy. They're standard risk. They're not at high risk of bleeding. Platelets 50 to 75, increased risk. High risk if platelets are 20 to 50. Very high risk if the platelets are less than 20. I know some centres use ROTEMs to look at clot thickness and clotting time by the bedside in obstetric patients and ITP patients. So this isn't gestational thrombocytopenia, but ITP patients often have got such fantastically oomphy platelets that they have normal MCFs, even with platelet counts down about 30, because they're just very effective. So again, I tend to think, I personally think of numbers as a guide, but I'm not wielding the needle. I'm concerned about the adverse events. But so considered increased risk platelets 50 to 75, but again, in that setting, would you, if you felt it was imperative that woman had a regional block, would you do an epidural with that with a platelet count of 60? Who? Pardon? You might think about spinal. Okay, but you would consider spinal. Yeah. Okay. Right. So she did uneventful spontaneous delivery. She didn't require prophylaxis. She was young and otherwise well. Cord blood on the baby. So basically, if we consider ITP as a diagnosis, obviously you can get transplacental transfer of IgG antibodies, and the baby can be thrombocytopenic. So anybody who's got a thrombocytopenia, we initiate PID alerts in case the baby's in the case that it is ITP and the baby's thrombocytopenic. But the baby's counts were normal, and her platelets were normal at 3 months. So we confirmed she had gestational thrombocytopenia. And most women, and certainly we've now looked after a good handful of women who've had subsequent pregnancies, and they do the same thing at each pregnancy with very similar nadir platelet counts in those. I mean, that'll be familiar to you all. Similar. 32-year-old woman, 28 weeks gestation, second pregnancy, came to the antenatal clinic with new onset spontaneous bruising and epistaxis. Again, she had a happy haemoglobin and white cell count, but she was significantly thrombocytopenic. Platelets were 9. So she was seen for assessment. First pregnancy uneventful, no bleeding history, viral illness a bit earlier, no other medical history, taking no medication. She'd marked petechiae of her limbs and oral mucosa. She had a large bruise on her thigh. She was otherwise nothing to find in examination. Baby was doing fine. Booking bloods were normal. So what are we thinking about here? Normal haemoglobin, normal white cell count, history of viral illness, bruising. Sorry, pardon?
Is it
Haematological? No, we're haematologists. We send them off to rheumatology. No, not with normal platelet count. No, so Haematological purpura, you can get the rash, but you don't tend to get the marked thrombocytopenia. So what we're thinking of someone with who's previously well, with a new onset of thrombocytopenia, with symptoms, who's otherwise well, with a preceding viral illness. We're thinking ITP, immune thrombocytopenic purpura, because often there's a preceding illness triggering it off. And it's more common in children and young women. So her repeat full blood count was unchanged. Blood film was normal. Really important to look at a blood film in people with thrombocytopenia, which I'll talk about with the next case. She had big platelets. Coagulation screen completely normal. She didn't have DIC. Hematinics were normal. She didn't have B12 and folate deficiency, which can be causes of thrombocytopenia. Antiphospholipid antibody testing we did do because we can, because patients with antiphospholipid syndrome can present in pregnancy with complications, and thrombocytopenia is associated with antiphospholipid syndrome. So we felt she had ITP. She didn't fit within the gestational thrombocytopenia cohort to us. Very significant thrombocytopenia, bleeding, bruising, previous pregnancy was fine. So we treated her. We definitely treated her. So what are our treatment options? Prednisolone 20 milligrams a day or intravenous immunoglobulin. We gave her both because she was bleeding. So if we're concerned about someone, we'll sort of shuck it all in. If she'd had a platelet count of, say, 20, 30 without any bruising earlier in pregnancy, I would have given her 20 milligrams of prednisolone a day. I wouldn't have given the intravenous immunoglobulin. If she'd had a platelet count of 35, we felt it was ITP, and she was 36 weeks gestation, but she had no bleeding or bruising, I may well have given her just intravenous immunoglobulin. The rationale being that what we want to do is get the platelet up for delivery, the platelet count up for delivery, and intravenous immunoglobulin tends to work in 3 to 5 days, and you get a response for up to a month. Okay, so it's about choosing your therapeutic option to maximise the effect to reduce the morbidity in the individual. Intravenous immunoglobulin, to maintain the platelet count, you would need to give in someone like this, it's every 3 to 4 weeks if it was for a period of time in pregnancy, whereas prednisolone, 20 milligrams a day, and once you get response, you can reduce the dose. So what are our treatment options? What are our treatment intentions? The treatment intention of ITP in pregnancy is to make sure they don't bleed, and ideally to keep the platelet count above 20 to 30. Okay, so that's our 2 treatment aims for earlier in pregnancy. And of course, the aim as we come up to delivery is to get a safe platelet count for delivery. And there, as I was saying earlier, if we're going to treat, let's aim to get it above 75, so it gives you all the options, or lets the women have all the options for regarding anaesthesia. And of course, in this woman with ITP, we're convinced it's ITP. She's got an immune-mediated etiology. We've got a higher threshold of being concerned about the baby, or being aware that the baby might be thrombocytopenic. So, again, I've been doing obstetric haematology clinic in Sheffield now for 13 years. I've only had 2 individuals who have had significant ITP in pregnancy that have had thrombocytopenic babies. And I think we certainly haven't given steroids to more than 8 women in pregnancy for ITP. So it's not common. This isn't common. Anyone get any questions about those? Mm. So this woman, she was bleeding, and she was at 28 weeks. So we treated her, and we gave her steroids and intravenous immunoglobulin, and her platelet count increased, but then fell again. So we gave her more intravenous immunoglobulin. Our treatment intention for her was to make sure we got the platelets above 30, and certainly from 36 weeks onwards above 75. And so she required steroids and intermittent intravenous immunoglobulin until delivery, and she also required some ongoing treatment for about 3 months after, and then the ITP resolved. So it was transient with viral illness, and this woman subsequently disappeared. Okay. ITP is funny, but a third of people, well, young adults and children often shake it off, and they have ITP for 6 months to a year, and then it resolves. But in older adults, they can have significant thrombocytopenias lifelong. They can be a challenge to manage. And 2/3 of people respond to any of the therapies that we offer, including a number of chemotherapy regimes, rituximab, we now use immune modulators, and we've now got what we call thrombopoietin analogues. One's called eltrompopag, and the other is romiplostim, which stimulate the megakaryocytes in the bone marrow to make extra platelets. We don't use them in pregnancy. So this lady, again, is in from Chesterfield. I think this lady was a Chesterfield, I'm sure she was Chesterfield, came to us about 6 years ago. 18-year-old, prima gravida, 39 weeks gestation, came in with headache, dizziness, peripheral edema, hematuria and oliguria. Hemoglobin 9.1 grams per litre, white count 13, platelet count 15. So what's different about this woman? She wasn't well. She really didn't feel right. She had a headache, felt unwell, was edematous, had hematuria, was thrombocytopenic, and it was felt there's something else going on here. So she was seen for assessment. She wasn't on any other medication. She'd been well until that point. She had borderline blood pressure. She had proteinuria, no glycosuria. Baby was small on ultrasound on the 5th centile. Booking bloods had been normal for her. Further investigations, she was more anemic in the repeat full blood counts, the hemoglobin down to 8.5 grams. Coagulation screen showed fibrinogen to be as one would expect. Renal function was normal, liver function normal, but her LDH was 3,388. Normal LDH, depends on the lab hours, is up to 460, I think. So that wasn't right. And this is her blood film. And this was her blood film. And you can see lots of little dense red cell fragments in the film. So this woman had, and this is why we particularly want blood films on thrombocytopenic people. So this woman had microangiopathic hemolytic anemia. So I've got a rather shocking table. But basically, differential diagnosis of microangiopathic hemolytic anemia in pregnancy. This is from our haematology guidelines. We do like our bizarre tables. So we've got, if we run down the left-hand side, what goes through our mind is this preeclampsia? She's got a borderline blood pressure, Maybe, but not quite right for that degree of haematological abnormality. Her liver tests were normal. TTP is what it turned out to be. Hemolytic uremic syndrome, her renal function was normal. Acute fatty liver of pregnancy, liver's fine. SLE, nothing to suggest it. Antiphospholipid syndrome, again, we're sort of thinking possibilities here. But really, she fitted with TTP. She had a microangiopathic hemolytic anemia. She had marked thrombocytopenia. Clotting was normal. Blood pressure was borderline, which we can see with TTP. She had some abdopain, creatinine, and you do get increased in some individuals, and she had CNS symptoms. She was dizzy, she was lightheaded, she was unwell. So she had thrombotic thrombocytopenic purpura. Now, TTP is one of these. Has anyone seen anyone with TTP? Yeah. Was that, when was that?
This is an intensive care setting, but not in the pregnant.
Okay. So a rare disorder, we should see about 5 or 6 a year in Sheffield, but they come like buses. We don't see any for a year and then they all come at once. You've got the pen tab to make the diagnosis. So you've got anemia with fragments, thrombocytopenia, neurological impairment, pyrexia and renal impairment. So you get the typical pentad of symptoms. It's an autoimmune disorder. Interestingly, we're more often now seeing cases of inherited TTP. So it's an absence of an enzyme. And that's what this woman turned out to have. She ended up having inherited what they used to call Upshaw-Johnson syndrome. So inherited TTP. How do we manage these patients? If somebody has got a microangiopathic hemolytic anemia in pregnancy, and it can't be fully explained by a non-TTP cause, we need to plasma exchange them. Plasma exchange is a nightmare. So, but you need to plasma exchange them. If we're convinced it's fatty liver of pregnancy, if we're convinced it's something else, fine. But if we can't exclude it, we need to plasma exchange. There's been a real drive to better diagnose atypical HUS patients and better recently, and so the assay to make a diagnosis of TTP is now available 24 hours, is effectively available certainly Monday to Friday in our unit in Sheffield now, and we're hopefully going to go to a 7-day-a-week service. So it's called an ADAMPS 13 assay. I can tell you more about TTP at another day, but it's a talk in itself. But basically, we can do an assay for TTP Monday to Friday at this point in time in Sheffield. If you think you've got someone that's got TTP, speak to your local friendly haematologist. If you don't plasma exchange them, they die, or they end up having a stroke. There was a patient when I was in Cardiff who ended up with occipital blindness, who had a stroke despite treatment. It's got a mortality of 10% even with best treatment. So, if in doubt, speak to haematology and exchange. So what do we do with her? Well, she came in the middle of the night. She needed to deliver. She was in labour. So what did we do? Gave her, luckily it was Joost van Veen that was on call, not me. So she was given octoplas, platelets, because she was thrombocytopenic and there was some uncertainty over the diagnosis. We hadn't made it yet, and she was thrombocytopenic and had hematuria, and did a caesarean section, and then exchanged her, did plasma exchanges. She rapidly returned to normal. Subsequent investigations confirmed that the ADAMPS was low. There was no detectable to the ADAMPS, and we subsequently diagnosed as a congenital TTP. You can get pregnancy in autoimmune-induced TTP. That's more common than congenital. And such individuals tend to need plasma exchanges for often up to 2 or 3 weeks to get on top of the disease. But she's so rapidly normalised. She was behaving like someone with a congenital deficiency of this ADAMPS. She's had a subsequent pregnancy and she is now doing very well in the community. She's not had any adverse outcome from this. Right, how are we doing? Oof, running out of time. Case 4, a 32-year-old lady, left leg swelling at 24 weeks gestation, and investigation confirmed a left femoral DVT. What proportion of DVTs in pregnancy are in the left leg? 90%. So there's a rule being touted whether we should look at the left rule, so, but mostly in the left leg. She was started in treatment dose dalteparin, 7,500 units twice a day, and then seen in clinic at 34 weeks. Don't know if you know, but maternal death, VTE was a leading cause of maternal death. I'm sure you do know this. Certainly back in the 50s when anticoagulation was unknown as a treatment for VTE, but mortality is significantly reduced. And the most recent triennial edit showed that thromboembolic disease is no longer the leading cause of maternal death. So better diagnosis and treatment of VTE and better prevention strategies have significantly reduced the risk. So her leg, at 34 weeks, her leg was back to normal. Pregnancy otherwise was fine. How would you manage her delivery? So the DVT was at 24 weeks, and we're now 10 weeks later. What would you do? Okay, so we've got a number of guidelines to help us. We've got the green top obstetric guideline of how to manage thrombosis and the obstetric guideline for how we manage regional anaesthesia. So what are options for delivery? So we can allow her to labour spontaneously on the current treatment dose of dalteparin. We can allow her to labour spontaneously but have reduced the dose of dalteparin. We can put an IVC filter in. We could plan induction. And either give her low molecular weight heparin or unfractionated heparin in the peri-procedural time, or we can do an elective caesarean section with whichever anticoagulant you like. So I'm going to ask you to vote. So who would like to do option 1? Yep, okay. That is in keeping with the current RCOG guidelines, is to carry on with the treatment dose for minimum of 3 months and for at least 6 weeks after delivery. Who would do option 2? A lot of people want option 3 for... Option 3, IVC filter. Yeah, something filter, thank you. Plan induction. Okay. Plan elective caesarean section. Okay. All right. So, I'll go for the easy one first. IVC filter. Don't do it. IVC filters we use if somebody has had an acute VTE event within the previous 4 to 6 weeks. And if we think they're at high risk of having another one and we have to stop anticoagulation. So far, I've never had to use one in pregnancy, and we recently had a patient from one of the outlying hospitals came into Sheffield and delivered here, was 2 weeks after a big femoral DVT. So we try to avoid it. So if possible, we try to avoid filters. They can turn, they can get stuck, they can get full of clot, you can't get them out. If possible, don't use. The risk of having a recurrent thrombosis, once you've got at least 2 to 4 weeks after the acute event, your risk of having another thrombosis is lower than the risk of the complications of the filter. Okay, so 4 weeks is sort of the magic number. She was about 10 weeks. Plan induction. What proportion of inductions fail in prima gravida? How many? 50%? Yeah, and so I think induction's a nice idea, but also I can't get my head around induction as haematologists. They come in, they get assessed, they get a propus, you check again later, you take it out, you put another one in, you check, you might do ARMs, you do this, and then you do that. And it just takes my simple brain. When do you give the dalteparin then? And how do we make sure we still give them dalteparin if we're going to induce? So actually, we do induce some individuals if they're multiparous or they're not prima gravida, and it gives us some more control over the delivery. But I don't really like that one so much. In some instances, it's the right thing to do, but we're not going to do it here. We're not going to go down an elective caesarean section because there's no other reason to give her one. And obviously, if she's a section now, then that's got implications for future, and it increases the thrombotic risk. So RCOG says allow to labour spontaneously in the current treatment dose, or you can drop the dose down. What we tend to have done in Sheffield, and there's very little evidence to guide any of this, is if someone is a good 10 to 12 weeks, 8 weeks after the start of anticoagulation, and their leg is much better, they're clinically well, it's going the right direction, then I think it's reasonable to drop the dose of dalteparin down as you're coming up towards delivery. And 5,000 twice a day is quite a nice dose, because generally we feel that if you're 12 hours after a 5,000 units dose of dalteparin, it's reasonable for them to have regional anaesthesia if you require it. So what my views would be with this lady is 1 or 2, depending how concerned you are about the risk of her limb and concerned you are about the risk of delivery. Obviously, if she goes into active labour, what we suggest, if she thinks she's going to labour, stop the anticoagulant and come into hospital. I mean, you'll know much better than me, but how many women do you think you have to deny regional anaesthesia on the basis of prophylactic anticoagulation? There's not many. There's not many. So I think largely, you know, if people are told don't have any if you think there's something, don't have any heparin if you think something's happening, then most individuals, you're not restricting significantly their options. The one woman, I don't like unfractionated heparin infusions. They're a nightmare to monitor. They can be really troublesome. The only time I've used that is somebody who had this deviated thrombosis 2 weeks earlier. The leg was getting better, had to deliver her, and I think she did have a caesarean section, and because it was felt necessary to control the anticoagulation very tightly, and she'd unfractionated heparin infusion. Okay, we're running out of time. Will I do some quick bits about inherited bleeding disorders and then stop? Is that all right? Sorry. 28-year-old woman, gravida 4 para 3, known to have von Willebrand's disease. Von Willebrand's disease, people have 2 different types of coagulation defect. They have low von Willebrand factor activity, and they have low factor VIII levels, because factor VIII is bound to the von Willebrand factor in the circulation. So if your von Willebrand factor is low, you lose your factor VIII. Okay? So her factor VIII levels were just at the lower end of normal. Von Willebrand's disease, acute phase reactant protein levels in pregnancy go up. Okay? At 32 weeks gestation, her von Willebrand factor activity had doubled. Her factor VIII was well within the normal range, 160%. Normal. How would you manage her delivery? Do we think we should normalise her von Willebrand factor activity? Yes. Von Willebrand factor is important for primary hemostasis. So if you cut yourself, what happens is the von Willebrand factor sticks to the cut surface, opens up, grabs the platelets and makes that primary clot. If you don't have enough von Willebrand factor, you will bleed. So we do want to normalise that. So her weight was 105 kilos, 2 previous emergency caesarean sections, so we planned for an elective section. Discussed with us in the haemophilia centre, and we gave her some von Willebrand factor concentrate before she had the caesarean section. She had a regional anaesthetic. Now, von Willebrand factor is really interesting. We're geeky. It's you, as well as having it in the circulation produced by endothelial cells, it's also in platelets. So when we give von Willebrand factor, we normalise the circulating von Willebrand factor, but we don't know what it does with the platelet von Willebrand factor. So sometimes people with type 2 von Willebrand's disease, which means abnormal functioning von Willebrand factor, they get a bit twitchy about regional anaesthesia, but it's weighing up the pros and cons. Was it you, Martin, who said we were saying, oh, regional anaesthesia, and the answer was, well, she had it the last time. So, okay then. And it all went completely straightforwardly. Tranexamic acid, we do like our tranexamic acid. It helps to stabilise, it's an antifibrinolytic, it stabilises the clot when it's formed. And in people that we're concerned about bleeding postpartum, we like to give them tranexamic acid. When she's delivered, her von Willebrand's disease will go back to its pre-pregnancy state, which means that her von Willebrand factor parameters will fall. So I'm going to talk very briefly von Willebrand's disease, factor 11 deficiency, platelet function defects, carriers of haemophilia. Von Willebrand disease is common. It's thought to be between 1 in 100 and 1 in 1,000 individuals. It's diagnosed more in women because women get menorrhagia, and whether it's a coincidental diagnosis. Levels are lower in individuals with blood group O. People with type 1, which is reduced quantity of a normal protein, it usually normalises by the time of delivery. So in the peripheral hospitals, you will see quite a number of these patients, I would expect, going through having normal deliveries in Chesterfield, Barnsley, etc. There's no need for them to come into a specialist centre if they normalise their levels. Just think about what the earlier levels were and think about the risk of secondary PPH. Type 2 and 3 will need to be managed in conjunction with a haemophilia centre, as they're likely to need concentrate. And we can give them plasma-derived clotting factors to normalise a von Willebrand factor. Carriership of haemophilia. I don't know if you know, with extreme lionisation, some women who are carriers of haemophilia have very low levels. We've got some women who've got levels of 2% of factor VIII, so very low levels. Most carriers, if they have low levels, will normalise them by term for haemophilia A, and if not, we can give them treatment to increase the levels. People who are carriers of haemophilia B, if they've got low levels, they will remain low throughout pregnancy. They do not change, and they will need factor 9 treatment. We've probably got a few dozen carriers of haemophilia on our books with borderline low levels. So you will come across these individuals, and the important thing for the mother is just make sure we've checked the levels, ensure that they normalise if it's haemophilia A. If they're a carrier of severe haemophilia in a male baby, we tend to do amniocentesis at 34 weeks, 36 weeks, to see if the baby's affected, as we would then offer them elective caesarean section. Otherwise, if they are delivering with if they've got a mild or moderate haemophilia A carrier, their baby might have low levels. So we do recommend avoiding trauma to the baby. Have you come across factor 11 deficiency? That's something I think you all will come across. It's actually quite common. We're seeing it increasingly because we're doing clotting screens. Your factor 11 level, it's not X-linked. Factor 11 level in mild 11 deficiency is normally between 30 and 50%, so 0.3 to 0.5. The bleeding phenotype is variable. Essentially, we don't think these people bleed significantly, but there's a big body of historic literature suggesting that some do, but we don't think they do. But the problem is, we can't guarantee it, so we do suggest with these individuals that you avoid spinal or epidural anaesthesia. But we give tranexamic acid, because factor 11 can lead to increased fibrinolysis. Once you make your clot, it can break it up faster. So tranexamic acid is the treatment of choice for these individuals. And very rarely do they need octoplas and usual thromboprophylaxis. Again, you might come across some people with mild platelet function defects. There aren't many of these individuals. And how we would manage them is giving desmopressin at the time of delivery, as it increases platelet stickiness, and then tranexamic acid, our favourite drug, but avoiding spinal or epidural anaesthesia, because we cannot predictably reverse the platelet function defect. So, yeah. And I'm going to stop there because I've well and truly run out of time, but I'm happy to talk about the new guidelines for obstetric major hemorrhage guidelines at lunch if anybody wants to nobble me. Sorry. Thank you.